If you're an emergency medicine practitioner, especially if you're an ACCS trainee or more senior doing shifts in an NHS emergency department, procedural sedation is one of those things. It looks straightforward on paper, but in practice, it demands absolute vigilance. Welcome to the Deep Dive. Our mission today is really specific. We want to help move you from just being competent to being genuinely excellent at delivering safe procedural sedation and, basic anesthetic care. We're synthesizing a whole body of evidence, and it's all rooted firmly in the national standards from RCEM and the AoMRC, which, well, they basically insist we treat every sedation with the same care we'd reserve for a general anesthetic.
That's the key, isn't it? The documents are so clear. This isn't just about what drug you pick. It's a whole safety system. The core insight we really want to hammer home today is that mastery. It hinges on meticulous preparation, on optimizing your environment, unwavering airway stewardship, and crucially, managing those human factors in what can be a really chaotic place.
Exactly. So we've pulled this all together into 5 crucial phases of excellence: knowledge foundation, preparation, execution, RSI assistance, and finally, recovery. And we should be clear, we are focusing this specifically on ASA 1, maybe 1E, and 2 or 2E patients, so the relatively fit ones.
Right, because if you can master safety here, you build the muscle memory, the capability to manage the inevitable complications when things really do go sideways with sicker patients. And that really is the proactive standard we're defining as excellence. The expert doesn't just react to a crisis, they create the safe environment before the drugs are even pushed.
Okay, let's unpack that. The absolute prerequisites before we even think about touching the pharmacology. Formal assessment. Why is a documented airway assessment so critical, rather than just, having a quick look?
Because it forces you to predict and to plan. I mean, if you anticipate difficulty, you can plan for it. If you don't write it down, have you really committed to that plan? It holds you to account.
And the structured approach that's championed everywhere is the lemon mnemonic. It's simple, but it stops you missing those big anatomical red flags.
It does. So L is look externally. Is the patient obese? Do they have a small mandible, a receding chin? Is there any obvious facial trauma? These are all macroscopic markers of potential difficulty.
Then you move to E, evaluate using the 3-3-2 rule. This is all about functional anatomy. So you're checking the interincisor distance, which should be at least 3 of their fingers wide. Then the hyoid to chin distance, also 3 fingers. And finally, that thyroid notch to floor of the mouth distance, which needs to be 2 fingers.
And here's the crucial bit for an ACCS trainee. If you find a restriction on any of those, say they can only manage a 2-finger gap between their teeth, that's your instant trigger.
Right.
That tells you that you need specialized equipment ready to go. You've just identified a likely difficult intubation or at the very least a difficult bag mask seal. So that immediately brings your plan B, your supraglottic airway, and plan C, 2-person BVM, right to the front of your mind.
We round out lemon with M for Malampati score, O for obstruction, stridor swelling, and N for neck mobility. That last one gets overlooked a lot, but if they have a stiff neck or they're in a collar, you lose all your positioning leverage. And, don't forget that little detail. Check their dentition. Loose crowns or caps can very quickly become airway foreign bodies.
That anatomical survey is foundational, but it's really only half the story. Sedation is a physiological stress test. So you have to follow it up with the full pre-procedural physiological evaluation. The good old ABCDE framework.
That's where you assign the ASA classification.
Exactly. So A for airway and B for breathing. That covers their history, snoring, asthma, COPD. But let's zoom in on C, circulation. Why is that so critical for sedation?
Because that's your biggest risk for things going wrong once you push the drugs, especially something like Propofol. You're looking for cardiovascular issues, ischemic heart disease, and so critically in the ED, their fluid status. A septic, volume-depleted patient is just primed for catastrophic hypotension under sedation. You have to see that and manage it before you draw up a single syringe.
Absolutely. Then D for disability, you're noting their baseline GCS and any substance use, which can just dramatically alter drug metabolism. And E, exposure, that's for an accurate weight for your dosing and, as you said, applying that ASA classification. It's the required risk stratification.
So once we've established that baseline, the focus shifts from a static assessment to, real-time defense, which brings us to monitoring. And here is the single critical takeaway from all the national guidance. Capnography is mandatory.
And we need to talk about why, because we still see a poor uptake of this in some busy EDs. Even though it is non-negotiable, capnography gives you a breath-by-breath analysis of ventilation.
Whereas SpO2, pulse oximetry, it has a huge lag time, doesn't it?
A massive lag time. If your patient is healthy and you've pre-oxygenated them well, their SATs might not drop below 93% for minutes after they've stopped breathing.
And that's just wasted time. In a crisis, time is everything. Capnography gives you an instant audible and visual warning. The waveform goes flat, instantly that you've got apnoea or complete obstruction.
And learning the shapes is key. A normal waveform is a nice square. But if you see it getting damped or a shark fin shape, that's your real-time signal of a partial obstruction like snoring or even early laryngospasm.
So you can intervene.
You can intervene with just a simple jaw thrust before it becomes a full-blown crisis.
And beyond that, the mandatory suite, of course, requires continuous ECG and NIBP, non-invasive blood pressure, which you have to cycle every 3 to 5 minutes to catch those predictable hemodynamic shifts.
Right. This is phase 2, preparation and the environment. This is where we move from theory to action. And honestly, it's the highest leverage point for safety. We use this OPAMI checklist, but we're not just, ticking boxes. We're talking about proactive placement.
Getting things ready.
And getting the team ready. So S is for suction. Is it on? Is it working? And is the rigid Yankauer catheter actually under the patient's pillow? I've seen this detail missed so many times in a chaotic Reese's Bay.
And if they vomit?
If they vomit and the suction is across the room or it isn't even turned on, you have an instant catastrophic failure.
That Yankauer under the pillow is pure gold. It's all about ready access. Okay, O for oxygen, high flow source, BVM connected and checked, nasal cannulae ready. A for airway, your OPA, NPA, a checked laryngoscope, and crucially, a rescue device.
A supraglottic airway, yeah. An iGel or an LMA of the right size, ready to grab.
Then P for pharmacy. All your drugs are drawn up, clearly labeled, IV flush ready, and this is the big one, the emergency drugs. Ephedrine, atropine, metaraminol,
Yeah.
They have to be immediately to hand.
Not in a cupboard down the corridor. They need to be on the trolley, within arm's reach. Then M for monitoring, checked and working. And E for equipment, which usually means defibrillator pads already on if you're sedating a high-risk cardiac patient.
Once the kit is ready, we deal with the human factor, the team brief, the formal timeout. It is absolutely non-negotiable. You have to assign crystal clear roles. Who's the airway doctor, who's the proceduralist, who's monitoring and scribing.
But the crux of it, the thing that really defines an expert team, is verbalizing Plan B out loud. It's stress inoculation. You have to actually say, if the patient desaturates or becomes hypotensive, we will stop the procedure immediately, perform a jaw thrust, and the monitoring nurse will pass the BVM to the airway doctor.
That verbal commitment creates a shared mental model. It stops the whole team from freezing when a crisis hits. And then, just before you push that first drug, you hit the single most important step for maintaining their oxygen reserve. Pre-oxygenation.
This is so key.
Yeah.
Apply nasal cannulae at 15 liters per minute before the sedation even starts, and you leave them on throughout the whole thing. This is apnoic oxygenation, or no decit.
And why do we leave them on during that potential apnea?
It works through the Venturi effect. It's delivering this high concentration of oxygen into the pharynx. And if the patient stops breathing, that high flow continues to passively diffuse into the lungs. It delays desaturation significantly. It buys you crucial time to sort the airway out.
You're aiming for denitrogenation.
That's the technical goal, yeah. An end-tidal O2 concentration of over 85%.
So once that whole safety system is built, we can turn to the agents themselves. The knowledge foundation means you really have to understand the trade-offs of the 4 key drugs mentioned in the sources. Let's start with Propofol. It's brilliant for deep sedation, rapid on, rapid off, but the risk.
Significant hypotension. You should be expecting a drop in blood pressure of more than 15%.
And that expected drop means it's basically contraindicated in your septic, volume-depleted patients, right?
Unless you have your vasopressors primed and ready to go. It's a fast track, but it demands absolute vigilance.
Okay, then there's ketamine, dissociative. The massive pro is that it preserves respiratory drive, airway reflexes, and it's hemodynamically stable. It's the safer choice for trauma or sepsis.
But it's not without its own risks. Laryngospasm, while rare about a 0.3% risk, is a major complication. And that emergence phenomenon, the agitation during recovery, needs careful management. Often just reassurance in a quiet room, maybe small doses of midazolam if it's really severe.
And midazolam itself is mainly for anxiolysis, for amnesia. It's reversible with flumazenil, which is great, but it does cause respiratory depression and it can accumulate in renal failure. And finally, fentanyl for pain relief.
Cardiostable, which is good. Its primary risk is synergism. It dramatically increases the respiratory depression when you combine it with other sedatives.
And the execution tip they all stress.
Start low, go slow, titrate to effect, and flush the IV line vigorously between boluses. That dead space stacking, where the dose you thought you gave is sitting in the cannula tubing and hits the patient 5 minutes later, that's a common error. It leads to overshoot sedation.
Right, phase 4. This elevates us to being a competent assistant in the most critical airway scenarios. RSI. And this is where all that prep pays off. You need to be fluent in the technical stuff, like the correct application and release of cricoid pressure, 10 newtons when they're awake, 30 when they're asleep.
And knowing to release it if it's actually obstructing the view for the person with the laryngoscope.
Exactly.
But the real excellence here is mastering the DAS, Difficult Airway Society, timeout script. It's a structured, verbalized failure plan, and it's designed to achieve one thing above all else: cognitive offloading.
That's the key phrase, isn't it? When you're under acute stress, your thinking just narrows. Having a pre-rehearsed script stops you from having to invent a plan in the middle of a crisis.
Let's just walk through the verbalization of that 4-plan strategy. It has to be stated clearly by the person pushing the drugs before induction starts. Plan A is your primary strategy. We will use the video laryngoscope and a bougie with the head ramped up at 30 degrees. Simple. Plan B is rescue oxygenation. If I fail to intubate after a maximum of 2 attempts, or if the SATs drop below 90%, I will stop and we will insert the size 4 eye gel.
And that's a clear, hard limit. 2 attempts. That's based on data. Attempts 3 and 4 just have rapidly diminishing returns, and they massively increase the risk of hypoxia.
Precisely. Then Plan C, if the supraglottic airway fails. We move immediately to a 2-person bag valve mask ventilation with an oral airway. And finally, the ultimate escalation, Plan D. If we cannot intubate and cannot oxygenate, this is a CICO situation. I will declare CICO and perform front-of-neck access using the standard scalpel bougie tube technique.
Using those standardized phrases is just so essential for maintaining control. So if your first attempt fails, you don't just mutter something, you have to verbalize it.
Yeah, you say, attempt 1 failed, saturations are stable, I'm going to optimize, change my blade, and adjust the head position. Going for attempt 2.
And when you hit that hard limit,
you have to declare failure clearly. Attempt 2 failed. I am moving to Plan B. Pass me the eye gel. This cognitive offloading is so crucial because it gives the whole team a definitive next step. It stops the operator from falling into task fixation and just trying again and again while the patient's SATs are plummeting.
and the final vital safety barrier we have to empower in the ED is the monitoring nurse or the scribe.
Oh, absolutely.
You have to explicitly say to them, call out clearly and loudly if the SATs drop below 93% or if hypotension occurs. That gives them permission in that really high-stakes environment to interrupt the most senior person at the head of the bed. It could be the difference between a near miss and a disaster.
Let's move to Phase 5, post-procedure and recovery. The 4th National Audit Project, NAP4, was a really harsh lesson here. It showed that a significant number of serious airway disasters happen not during the procedure, but in the recovery phase. People just relax too soon.
We need to understand why that is. It's often due to delayed drug stacking, isn't it? Especially opioid respiratory depression from fentanyl kicking in late, or maybe delayed airway swelling in a trauma patient.
Yeah. So the standard has to be unwavering. Monitoring must continue 1-to-1 until the patient is awake, responsive, and talking. You never, ever leave a recovering patient unattended.
And for discharge from recovery, you need a formal criteria, something like the Aldrich score, to make sure there's a documented return to their baseline before they go to the ward or home.
Right.
Let's quickly run through the management for the most common severe complications, because anticipation is everything. If you get immediate significant hypotension, a drop of more than 15%, what's the move?
Those vasopressors, the ephedrine or metaraminol you had ready, they have to be used immediately, along with a fluid bolus, no delay.
Okay. For immediate respiratory depression or apnoea, which you'll see instantly from the loss of your capnography.
Stop everything. Aggressive airway maneuvers, jaw thrust, chin lift, and ventilate with the BVM. You only even think about reversal agents like flumazenil after you've reestablished oxygenation.
And if you encounter laryngospasm, that stridor, the tracheal tug.
The initial management is actually to deepen the sedation, often with a little more propofol, and apply continuous positive pressure with the BVM. For emergence phenomenon from ketamine and recovery, quiet reassurance is number one. You can escalate to small doses of midazolam if they're severely distressed.
Finally, for our ACCS trainees, evidencing all this competence is so critical for the portfolio. You need those workplace assessments.
You do. You should be aiming for 3 to 5 DOPS direct observation of procedural skills for sedation itself. And make sure you're assessed on the whole process, from that SOPME check right through to recovery.
And you're expected to log complex cases, that septic patients you were worried about or the physiologically compromised patient, in your CBD, your case-based discussion. It proves you can risk stratify and manage the human factors.
And things like simulation training, HALO or MCR courses, and the RCEM learning modules, they all contribute to showing that progression from just being competent to being truly expert.
So the summary insight we've really established here is that safe procedural sedation, it's a whole safety system, not just a single injection.
That's it. The practitioner has to always be prepared to rescue a patient who enters a deeper level of anesthesia than was intended. Your highest leverage points for safety aren't the drugs you choose, but the preparation mastering that SOPME checklist and your communication implementing that structured DAS timeout script.
Absolutely. The preparation phase is what defines the expert, especially working in a demanding NHS environment. So here's a final thought for you to mull over as you head into your next shift. Given the chaos of a busy ED, which single item on that SKPME checklist, suction, oxygen, airway, pharmacy, monitoring, or equipment, is most often forgotten or overlooked in your department? And what minor system change could you personally champion within your team to ensure that specific safety barrier is always ready, always checked, and always within reach? You can explore the full national guidance further with the RCEM and AoMRC standards online. Until the next deep dive, stay safe and stay proactive.